Hi, welcome to this section of cardiology. This is Dr. Jaitly. In this section, I will be talking to you very briefly the basics of mitral regurgitation. Now, there's exhaustive information available, obviously, in medical texts, journals, and other books, which you can always supplement, but just to give an idea as to what mitral regurgitation basically, what it looks like, how does it manifest acutely or chronically, and how do you achieve a diagnosis, and of course, what are the causes of mitral regurgitation. So here's a schematic of the heart on my left side of the panel that I wanted to show you. A mitral regurgitation occurs when the valves fail to close fully. That's called regurgitation. So when pertaining to mitral, it's called mitral regurgitation. Now normally the valves will open in one direction. So the left atrium, as we know, this is the left side of the heart, just to familiarize you quickly. The top chambers are the atria, these are the ventricles. So the left atrium, when it contracts, should ideally send the blood all the way down to the left ventricle during diastole, during the relaxation period of the ventricle. Now the ventricle begins to contract, the valves will start rising upwards, normal again, this is the normal phase. And so these valve leaflets will start floating upwards a little bit, and they approximate with each other so well that it's a tight closure. So the valve leaflets are tightly closing and separating the LA from LV. As a result, the blood can now be pumped into the aorta for distribution to the rest of the body. That's a normal phenomenon, and that's how it should be. So in other words, there's no backward flow. The flow came in from where? LA through the mitral valve into LV. LV takes the turn now to contract, sends the blood up in the aorta while the mitral valve is closed, shut tight. In the setting of mitral regurgitation, what happens is the valve leaflets do not approximate or pose with each other so tightly. Imagine a door which has been left ajar, so the air constantly escapes from one room to the other, correct? In the house. So if you close it fully, then obviously the air will not escape from one to the other. So the same thing is happening here. Remember, the heart is just like a house with the walls and doors. So the left atrium now will receive blood through this regurgitant valve, quote unquote, up into like this. And most of the blood, of course, will still be going via the aorta into the rest of the body. But some percentage will start to go back into the left atrium initially, and then later on over the weeks, months, years, decades, it'll start to increase even further. So the pathogenesis or the process of mitral regurgitation starts either because of a degenerative disease in the valve, that's called the wear and tear, we call it, past the age of 40, 45, pretty much a lot of population. If they were to have an echo, like the one I've shown you on the right side, they will demonstrate some trivial or mild mitral regurgitation. Now those are insignificant, specifically if there are no symptoms. So, but that's the usual wear and tear. Now let's understand what are the causes of mitral regurgitation. We are talking about the specific and the significant ones. Rheumatic heart disease, which is, as I mentioned in my earlier presentation, is a resurgence, unfortunately, occurring in developing and developed countries, both in different strata of populations. Mitral valve prolapse is up to 5% of the population has prolapse, and therefore the prolapsing of the valve leaflet into the left atrium will contribute to mitral regurgitation. Degenerative, we just talked about. The ischemia and infarct. Now, when there is a heart attack occurring, or there is unstable angina, we call it, or acute coronary insufficiency, where some of the muscle walls are weak, or there's an infarction. That means some portion of the mitral valve, some portion of the myocardial wall has been damaged by an abrupt cut off of blood supply, and a portion of the chordae may rupture as a result, or a papillary muscle may rupture. Now those are emergencies, by the way, and those acute, we call them acute MRs, and those acute MRs, like I've said here, it's an emergency situation where the patients actually end up in the surgical ICU and soon into the operating room to get the mitral replacement or mitral valve repaired. Chronic mitral regurgitation is more compatible with life, and the other causes that I've just enumerated are myxomatous degenerations, mitral valve prolapse syndrome, Marfan syndrome. Very tall individuals who have mitral valve as well as aortic valve predisposing factors of regurgitations. Then the calcification that occurs on these valve annuli. Remember, these the mitral valve apparatus itself, or the whole leaflets are attached to a ring, and that's called the mitral annulus ring. And that ring gets calcified again because of degenerative conditions, chronic damage, chronic inflammations, kidney conditions like renal failure. I've seen a lot of those in the renal failure patients. And then personally, I've seen them also in hypertensive individuals, or just an inherent tendency to calcify the annulus, which is prevalent in unexplained cases. So it's called MAC, M-A-C. It's mitral annular calcification. That occurs, and it's always an echocardiographic diagnosis. Occasionally somebody sees an X-ray, but nobody does an X-ray these days for the heart. Endocarditis, which is an infective process that occurs, and of course the mitral valve in those cases are involved, and I've discussed endocarditis at a different video vignette. So we have acute and chronic variety. A systolic murmur is a norm because remember, the left ventricle is contracting. So during contraction between S1 and S2, what will you hear? A systolic murmur, and that murmur will go through the mitral valve like this, and therefore it is also conducted to your axilla. So it's ideally heard at the apex of your chest wall, where the apex beat is, but it is also conducted to the axilla and systolic in time. So it's between S1 and S2. S1 obviously becomes soft because the mitral valve component is a prominent component of the S1 per se, and now if the mitral valve is not closing fully, the sound will be much softer, sometimes not audible. Prognostic purposes also, people like to do an echo, but diagnostic, let's shift it to the right side. Diagnostically, of course, mitral regurgitation will occur through this mitral valve in this position, where the systole occurs, and most of the valve, of course, is sending the blood into the aorta, but here now some blood is regurgitating back into the mitral valve, through the mitral valve into the left atrium. So the left atrium starts enlarging. Left ventricle also enlarges because of the volume, constant increased volume going back and forth, which is not an efficient way that the heart likes to function, obviously. So therefore, the left atrium and left ventricle will have to accommodate that excess volume of blood which is sitting on the left side. So the symptoms are obviously related to the left side first, which means fatigue, chronic weakness, shortness of breath. That's what the patients will originally present with. And then the symptoms of left ventricle dysfunction, like they may or may not have hemoptysis or blood in the sputum, sometimes when they're coughing up, chronic bronchitis, which is typical of mitral stenosis, not necessarily with mitral regurgitation, also occurs. And then the right-sided failures tend to develop, and those are hepatomegaly, which is liver enlargement, ankle edema, which is as straightforward as that, and then ascites, that means fluid collection within the peritoneal cavity, which is in the tummy. So outside the intestines and the rest of the abdominal organs, there is a sheath which is separating all the intra-abdominal organs from the rest of the abdominal cavity, and that is now containing fluid, and that's called ascites. So in advanced cases, one can also see a congestive heart failure because now the right-sided has failed and the left-sided, of course, has failed because that's where the original problem arose. So in a nutshell, the diagnosis is clinical, and then, of course, by echo, where one sees mitral regurgitation in a Doppler, color Doppler, which I would like to show you at a different time. And the LA will be increased in size and LV will be increased in size initially, but later on all four-chamber enlargement can occur in very advanced cases. Follow-up may require repeat echoes every 6 to 9 months or a year to see the mitral regurgitation is increasing, the LA size is varying, or if LV size or contractility is varying, etc., etc. And we'll talk about that more in detail later. But echo with stress is very helpful also because one gets to assess what happens to the mitral valve in a setting when somebody begins to exercise or walk on a treadmill. Okay, wonderful. I'll talk to you again, guys, and stay tuned for more of valvular discussions.